So you're in a bad mood, you're short. It's sort of, I think for me, when I think about progesterone, I'm like, it's the first domino.
Absolutely.
I'm like, it really is. I'm like, because you sleep badly, and it's sort of what came first, the chicken or the egg? Like, did the bad mood come first? Did the poor sleep? Did the fatigue? Did the physiological changes? Like, I don't feel right in my own skin. It doesn't really matter. Or did the lack of motivation? So now I'm not going to the gym, or I'm not cleaning the house. And then, house is a effing mess. Do you know what I mean? But I think for a lot of women, it does feel like that. It's not a clear line. It's just everything starts to just feel not right. Welcome to the Modern Menopause Podcast by Parlor Games. I'm your host, Morven, and I'm here with my co-host, Dr. Robyn Kutka, all-round expert in everything hormones, menopause, and so much more. This week, we're going to be tackling a pretty pervasive myth that happens during perimenopause and menopause that women hear a lot, which is all you need is estrogen. You enter perimenopause and menopause, therefore, according to this myth, your estrogen must be low and all the problems that you're having must be caused by low progesterone. So this is a pretty common one. We hear this all the time. Women are coming in and saying, I'm having hot flashes, I'm having weight gain, I'm having brain fog, mood swings, I'm having vaginal dryness, I'm having itchy ears, ringing in my ears, cotton mouth. I could list the sort of 45 symptoms, but especially those big ones, right? And they're thinking, okay, well, my estrogen must be low because this is what I've heard. And this is so common that the progesterone hormone, which is a big hormone, doesn't even enter the conversation for a lot of women. And so I'm going to hand it over to you, Dr. Robyn. What's kind of going on with this myth? What's happening here?
I want to talk about so many things, but first, let's just chat just briefly on the physiology of what's happening during this perimenopause and menopause transition, so people kind of understand where this comes from. So, yes, as we're entering menopause, certainly our pre-menopause levels, are declining of most hormones. But really, actually, what's happening is we're having some fluctuations too. So once we're perimenopausal, we're getting into the menopausal years, we're starting to have less cycles where we actually ovulate. So maybe we still bleed, but we didn't ovulate, or we ovulated, but maybe the tissue the egg came from didn't hang around and do its job long enough. So that tissue, part of its job is to make progesterone. So if we're not ovulating or it's not hanging around doing its job long enough, our progesterone levels plummet to almost zero because we only make a tiny bit in our adrenal glands. So that's plummeting to like almost zero while our estrogen levels are still fluctuating. We're yelling at the ovaries to make more, the brain is, or we're making some estrogen in our fat cells. So there becomes this, let's call it like a gap between the two, where progesterone's at almost zero, tiny bit from the adrenal glands, that's it. And our estrogen levels, maybe they're declining, maybe they're fluctuating, but they aren't necessarily quite as significant as a drop of what we might see in those, especially the perimenopausal years surrounding, leading up to menopause. And so this gap creates symptoms. And so for many women, actually what they don't need, if we gave them estrogen, we would simply further the gap versus giving them progesterone, we can close the gap and see some of those symptoms resolve.
Right. And it's interesting, right? Because I think that, like you're saying, estrogen might be declining, but just not at the same rate. And so women are thinking, man, these are all symptoms of high estrogen versus seeing them as symptoms of low progesterone, or that gap like you're talking about. So walk me through this, because, this has been so pervasive and women are in this position where they're maybe being prescribed estrogen or they're seeking out kind of treatments towards estrogen. Women weren't being given progesterone.
No.
Why is that? Why weren't we seeing this? Why wasn't it a thing?
This is a fabulous question. So when we think about hormones for women, while we've come a long way over the decades, we still have a really far way to go, and it really hasn't been individualized. So it's this one-size-fits-all approach. Oh, you're symptomatic? Here, take this estrogen. Oh, wait, but you also have a uterus? We should protect that. Take this progestogen. And that's still kind of our approach right now. But we have to differentiate some things in there. I don't agree with that approach. I think we need to individualize it more, but that is still our conventional approach. And we aren't all a one size fits all, right? But within that, I use the term progestogen, and progestogen is the broad term. It's like an umbrella term for anything progesterone or progestin. Progestin is a synthetic pharmaceutical that is not identical to what our body makes. In fact, it is what is in birth control, so it prevents a pregnancy, versus progesterone is identical to what our body makes and maintains a pregnancy. So they're very, very different molecules, but are often interchanged as if they're the same thing. So whether it's, a healthcare provider talking about it, whether it's a journal article, that one's frustrating, journal articles talking about it, or even patients, clients, lay people talking about it, they might interchange those words as if they're the same, and they're very, very different. What was studied in the Women's Health Initiative, so the Women's Health Initiative was this big study looking at hormones. It's where we got the idea that hormones are scary and cause breast cancer and all this stuff. So we'll tackle all that another day. But what was studied in that was progestin, one type of progestin called MPA. MPA is not progesterone. It is basically a medication. It does work at progesterone receptors, but in the body, its only positive action or beneficial action is to protect the uterus from the growth effects of estrogen. So estrogen is like a fertilizer, and if we give the body a bunch of fertilizer, that uterine lining, if we think of it as the garden, it's going to keep growing. So we have to give something to the body to keep it from growing unchecked. So that's where the progestogen, or in this case, the progestin MPA was given. But that's the only beneficial thing it does. It doesn't help us with any of our symptoms. It actually can increase the risk of breast cancer. It can increase the risk of cardiovascular events like blood clots, so stroke or heart attack. And so if women didn't have a uterus, they weren't given it. Of course. Why would we give them something that's going to increase risk of other conditions with no other benefit? So that's where this idea of we don't need it comes from. We just need estrogen. But progesterone, like we've mentioned, is really, really different, and it doesn't have any of those negative side effects. It does not increase our risk of breast cancer. It does not increase risk of cardiovascular events or blood clots or things. And in fact, it has many beneficial effects in the body. It's considered an anti-cancer hormone. It helps us with those symptoms of perimenopause and menopause. Things like brain fog, bone health, hot flashes, weight gain, sleep. Oh my gosh, so important for sleep. So mood. It does all these things without any of the negative side effects. So this is where I call it, the magical unicorn of hormones. It does all this great stuff, and there's no side effect. Why aren't we giving it to everybody? And it's just, that approach hasn't shifted despite us using something very different. We don't typically use MPA or progestin in hormone therapies anymore. Most people are using progesterone, but the other ideas behind it just really hasn't caught up.
Well, and it's interesting, right? Because you touched on a couple different things there, right? Is that whilst estrogen has this misconception, I would say to some degree, of being really dangerous, it's at least studied and researched and well known. So it is at least prescribed. Women can go to the doctors will tell them. But it sounds from what you're saying is progesterone just sort of didn't exist. It wasn't on the radar. It was, hey, there's progestin, which does this one really specific job, which is protect your uterus if you have one, or birth control, or it kind of functions in a pill. I think there's some IUDs that have progestin, right? Yep. And that's it. And because it's essentially single function, and it got lumped in with progesterone, that we just don't know about progesterone we do now. I know that that's sort of starting to change, that there is more research, but it sounds like this is sort of one of the challenges, because yes, estrogen maybe had a bad rap, but there was at least a lot of research. Did at least exist. Progesterone doesn't exist so much, which is pretty sad, because I'd love for you to talk about this in more detail. It's like, what is all the things that progesterone does? Because I know it has so many uses in the body. What's progesterone actually doing in the body? Because progesterone is the less common one.
Great question. And you're right. I think when women come back to me reporting, I don't know how to describe it. I just feel like myself. It's because we started this hormone, which is something they weren't given enough of previously. As a kind, it gets overlooked. So, progesterone has over 400 functions in our body, and a lot. So it is not. progestation. Of course, it maintains pregnancy, but it does so much more than that. And it's important for most systems in our body. From a symptom perspective, women can expect to see a shift for the better in their mood, in their bloating, in their sleep, maybe in their hot flashes, all sorts of things along those lines. But it's important for brain health. It's important for heart health. It's we call it an anti-cancer gene because it promotes something called apoptosis. Apoptosis is programmed cell death. So when cancer is present, those cells aren't dying. That's what cancer is it's just like kind of growth unchecked. It just keeps growing. So progesterone actually promotes cellular death. So we think of it as an anti-cancer hormone. It's important for our thyroid function. It actually makes our thyroid hormone more available because it decreases the proteins that bind it. So we get better thyroid hormone function. It increases the cells that build bone, so osteoblasts. So it promotes their function and activity. It doesn't increase the cells per se, but increases their function. And so, when we're thinking even about bone health, we're only usually focused as a medical community on estrogen, but progesterone is super important there. It helps lower cholesterol. It's a diuretic. So with that, some people feel less bloated or they lose weight. It's thermogenic, so it burns fat. I mean, it does. So it promotes our hair growth. It's amazing.
Right. You're like, even if you don't want it for all the health benefits, just the beauty benefits, nice skin, nice hair, there's your progesterone. Okay. I mean, it is a pretty impressive hormone, right? Mm-hmm. Talk to me a little bit more about balancing, because obviously, women in perimenopause often see probably the most obvious benefits from supplementing and adding some progesterone into the routine. Mm-hmm. Women in perimenopause are the ones who are seeing that progesterone decline. They have that bigger gap. I'm talking about women who haven't been using progesterone, right? So they start supplementing progesterone. They're going to see pretty dramatic results. What about women in menopause, post-menopause, as women are getting older? Mm-hmm. And maybe they've been in this state for a wee bit longer, or maybe they're using other hormones. They're using estriol, they're using estrogens, they're using DHEA. What role does progesterone have there? Because I think that there's a difference, right? There's a difference from a woman in her 40s who starts using progesterone, versus a woman in her 60s.
I think when we're thinking about perimenopause and that woman in her 40s, she's probably, I liken it to a roller coaster. She's on the thrill ride, right? We're trying to get her off the thrill ride and onto the kiddie coaster. And progesterone oftentimes does that for her. By the time we're menopausal, maybe we're only on the kiddie coaster. The thrill ride's kind of over and we probably aren't getting back to that, but we're not on even ground either. So this can kind of help bring women back to even ground in that analogy, and really fill the space for those nagging symptoms that are still there. For women who are complaining about feeling puffy, or maybe their GI isn't running as smoothly as they expected it to. They're more bloated or more gassy, or their bowel movements have shifted. They still haven't, maybe their hair loss has stopped, but they're not really getting the growth that they want. Or there's a little bit of sleep disturbance still left. Their mood's still off. And these are also, that's from a symptomatic perspective, but these are also the women who are usually seeing an increase in their cholesterol, a decrease in their bone health. Maybe that brain fog is still there and they're really struggling to pull for some of their words. So it can be the next step or the missing step in that approach.
Nice. Okay. Awesome. Well, we're going to bring in some questions. We always like to include questions from our customers for those of you listening. So we're going to get started because I think that this is a big one where there's a lot of our customers have questions about progesterone, or they've never even heard of progesterone until they find us. We have so many women who find us from Silky Beach, and then they join our private Facebook group and they're like, wait, what is this? What is this thing? What's going on here? So we get a lot of questions about it. So I heard someone mention there are over 400 receptors for progesterone in the body. What does that actually mean? And why does it matter for how I feel day to day?
I think probably what this person heard is 400 different functions. We definitely have more than 400 receptors, but the receptors are what bring something into a cell so our tissues can use it, or what accept a substance. But with this person in particular, I think what she's getting at is Yes, it has so many different functions, but what it means for day to day is feeling more like ourselves again. It's that nagging feeling of something's missing. I don't quite feel like myself. Maybe the motivation is gone. This even plays a role in libido. So when we're thinking about like things just feel off. I don't feel bad, but I just don't feel like me.
Great.
Yeah.
I don't feel bad, but I don't feel good either.
Yeah. That's
blah.
This may be why.
Blah. Yes. Okay. My doctor prescribed me something called Provera, which I've heard is progestin and not actual progesterone. Are those the same thing? Because I feel terrible on it.
Yeah, poor thing. They are not the same thing. So this is what we were talking about before. Provera is, does have progestin versus progesterone. And so that progestin can be protective to the uterus if there's been excessive bleeding or something like that. Progesterone can also be protective to the uterus while helping us with some of those other symptoms. And most docs aren't prescribing progestins anymore. They're typically prescribing progesterone, but it's still happening. So that would be a question to ask. Go back to the doctor and be like, "Hey, was this prescribed for a reason over progesterone? Why would I choose this?" And if it wasn't, maybe this person can shift over to actual progesterone and see if they feel better on that. They likely would.
Well, we have some other questions actually, but I want to touch on this before we continue, because I think one of the other issues here, right, is sort of we have women who are on progestin. They've been prescribed progestin from their doctors. There's that difference as well between oral progesterone, topical progesterone, and then, I mean, it's typically oral progestin, right? It's that's
Always.
the typical route.
Well, typical.
Yeah. So you've got women taking oral progestins, you've got women taking oral progesterone, and then you've got women taking topical progesterone. Because I know that this comes up all the time with someone saying, "Hey, I'm taking oral progesterone." So before we get into the next question, because I think that this is a pretty relevant distinction, to discuss for women when they're looking at, making a informed health choice.
Yeah. Oh, absolutely. And one thing I want to clarify here, progestins, I don't want to make them out to be evil. We need them in medicine for some things, right? So this is sometimes used by women who have, it's used short term, let's say for excessive bleeding or something like that, maybe while they're working up other things, or, so it will act fast. It will help with excessive menstrual bleeding. So what we're talking about today is using it instead of progesterone in menopausal hormone therapies or premenopausal hormone therapies. And there are, yes, it's an option, but if we're thinking about it for hormone therapies, there are better options. But, progesterone is one of them because, like we've said, it still protects the uterus, but also addresses our symptoms and several systems throughout the body. Like, when would we need one versus the other? We really wouldn't in hormone therapies. But if someone is also using estradiol, and they have a uterus. So let's say someone's using an estrogen patch. Super common right now. I love them. They're very easy to use. They're inexpensive. Typically, if people have insurance, they're bioidentical. So if somebody's using an estradiol patch and she has a uterus, we have to protect that uterus against the excessive growth effects of estrogen. So if we're not using progestogen here, we call that, it's unopposed, meaning we're not balancing out that estrogen. So we don't
There's no lawnmower.
There's no lawnmowers. Progesterone's the lawnmower. So we got to bring the lawnmowers, and we don't do unopposed estrogen in someone with a uterus. And so when this is the case, we want to be swallowing progesterone, and that's where that progesterone pill comes in. It's more protective to the uterus than, say, a topical progesterone. But when we swallow progesterone, it goes through the liver in something called first pass. And at first pass, the vast majority of it becomes another hormone and really isn't utilized as progesterone. So for most women, while that's enough to protect the uterus, it's not going to be enough to get rid of all of those symptoms that we chatted about. Getting, better hair, better mood. It definitely can help with sleep. Will it get them all the way there? I don't know. Thyroid stuff, weight stuff, bowel movements. And so for these women, addition of a topical can be very beneficial. And for women who aren't using an estradiol patch, then topical progesterone is great. Whatever's used is used as progesterone. Topical progesterone avoids first pass, so we don't lose the majority of it to that other hormone. And it's, So that's the main difference there. Yeah, because it's such a
common question, right? We hear from so many women who are like, I'm taking often an estrogen patch, funnily enough, and oral progesterone, and they're like, but I'm still having these issues.
Yes.
I'm still having X, Y, Z.
And this is why.
Yeah. And it's hard for women to understand, because then they're already sometimes lacking in support, and then they're sort of like, well, what else can I do at this point? What else can I do? And I think it's sort of understanding there's a big difference in the mechanism of how, if you take progesterone orally, it doesn't function the same way, which I think it's important for women to know.
Yeah. Well, and honestly, most providers don't know that. And so, why would patients? And so dosing here is going to look really different too. This is why an oral dose of progesterone is 100, 200, or maybe even 300 milligrams, because most of it's going to become another hormone. Versus a topical progesterone, we wouldn't give somebody 300 milligrams of topical progesterone. We would give them 20, 30 milligrams, something like that, maybe 40, kind of depending on the woman, how she absorbs it and her weight. But, yeah. And for a very select group of women, usually women who are on the more slender side, they're pushing, right around 100, 110 pounds, something like that. Maybe a patch and pill combo is going to be enough, because she's, but the average woman, I think the average weight these days is like 170, 160. We were looking that up for something else.
Right.
So for like an average woman, a patch pill combo won't be enough progesterone. And that's where they're feeling that kind of the missing link of, I'm doing all this, but I still feel off. There's still room for improvement. Mm-hmm.
And it's funny because it starts to interplay into that bigger cycle of perimenopause and menopause for women, right? Is that your sleep's shot, you're waking up all the time.
Yeah.
You're in a bad mood because you're tired and you still have to get everything done. You still have to go to work. You still have to make kids lunches. So you're in a bad mood. You're short. It's sort of, I think for me, when I think about progesterone, I'm like, it's the first domino.
Absolutely.
I'm like, it really is. I'm like, because you sleep badly, and it's sort of what came first, the chicken or the egg? Like, did the bad mood come first? Did the poor sleep? Did the fatigue? Did the physiological changes? Like, I don't feel right in my own skin. It doesn't really matter. Or did the lack of motivation? So now I'm not going to the gym, or I'm not cleaning the house. And then, house is a effing mess. Do you know what I mean? But I think for a lot of women, it does feel like that. It's not a clear line. It's just everything starts to just feel not right. And then it's like, okay, well, if I could just get a good night's sleep, then I'd be in a better mood. Then I'd go to the gym. But I can't get a good night's sleep, and then I'm in a bad mood, and then and I didn't get stuff done, so I go to bed and I'm not falling asleep because I'm thinking about the stuff. And so that's where I think progesterone really serves as that. It's that first domino of like, okay, well, if you can get a handle on a lot of this stuff, it's going to have this huge ripple effect in ways that you can't necessarily perceive, which, like you say, so many women come to you saying, yeah, I just feel human again, feel like myself. Okay, last question here. What is the difference between taking a progesterone pill and using a cream? Exactly. The positive and negatives of each. I don't want ChatGPT to give me this answer. I'd rather hear it from you ladies. Good.
Yeah, I love it. Okay. So obviously a route of delivery is different, right? So when we swallow the progesterone pill, it goes through first pass at the liver, first pass, anything we put in our mouths or anything we put in or on our body is going to end up going through the liver. But when we put it in our mouth, it goes through something called first pass. And at first pass, it changes. And that's where it kind of breaks down. And over 90% of our progesterone becomes another hormone. That hormone's name is allopregnanolone, not pregnenolone, allopregnanolone. And allopregnanolone works at GABA receptors in our brain, and so it's very sedating. So we always use our oral progesterone at night because it can make us really sleepy. Some women will actually use a little during the day for their anxiety because it's calming, but for the most part we use this at night. Versus topical progesterone can also work at the GABA receptors, not quite as potently, I would say, or as strongly as that, but can still work at GABA receptors and support sleep, and it's not going through first pass. So we can use most of it as progesterone. That being said, it's not as protective to the uterus. Some does make it to the uterus. We've seen that showed in histological studies, so where we take a piece of the uterus and look at it, but it makes it to the uterus. But once somebody's using like a systemic estradiol, I'm not talking like vaginal estrogen here, but like a estradiol patch, if they're still using estradiol pills, something like that, and they have a uterus, topical progesterone is not going to be enough to protect it. And that's where we would also swallow progesterone. So they can be used together. They can be standalone. So when we've talked about if you're using estrogen, we always want to use a progesterone with or without a uterus, versus if you're using progesterone, we don't have to also use estradiol or estriol or any of our estrogen. So, is one thing to keep in mind there. It can be a standalone as well.
Nice. Okay, awesome. Well, to those of our ladies, to everyone listening, if this sounds like you or this is something that you've ever struggled with, it's always a great thing to share this with other people because they might be struggling too. That's one of our goals here at Parlor Games, is to kind of spread the word and start the conversation about menopause and different kind of menopause myths that we come across. I will say we do have tons of blogs on this subject too. Our website is just parlor-games.com. We have a ton of blogs about this. So if you're curious and you want to learn more, we have guest blogs by Dr. Robyn. We have a bunch of blogs from our founder, Kate, who knows all things hormones. So if you're ever curious about this, because we know it's a difficult topic for women, be sure to go check out those blogs, or you can always send in questions that you might have that we will answer on this very podcast. So you can, submit your name, get a chance to be featured on the podcast if you'd like to. Otherwise, that's all we've got time for today. Be sure to share and tune in next time.